cure remains an urgent priority for the community of people living with HIV. We now have proof of concept that this is possible with up to 9 people worldwide with confirmed or potentially cured or in remission.
So one of the things that people don't really understand, Dr. Ming, is why is HIV so hard to cure?
It's a bit like in a spy movie where you see those scenes of spies changing their clothes, changing their outer appearances, hair colors, in a room at a party full of people, allowing them to go undetected. And it's the same with the virus.
It's fascinating, isn't it? The very subgroup of cells in our immune system that is meant to fight the infection, HIV is clever enough to attack that particular subset of cells and literally change the nature.
A really fascinating and clever virus in a way.
Let's talk about one of the cure strategies. What was the big question that you were trying to answer through the RIO study?
We were trying to investigate a new type of treatment called Broadly Neutralizing Antibodies to see if they could prevent the virus from rebounding once people stop taking their tablets. It just sets a route map to, firstly, we know a cure is achievable. We know that the immune system can be stimulated to clear HIV from the body.
Do you think that we will see a cure in our lifetime?
I think that is the million-pound question.
Hey everyone, and welcome back to Dose of Health. Today's episode is the one that I've been thinking of recording for a long time, because it's about something that goes beyond medicine and science. It's about hope, real hope. If you're living with HIV, you know the routine. Daily tablets, lifelong treatment, constant checkups. It's a rhythm that becomes part of your life. But what if one day the rhythm could change? What if the virus could stay undetectable even without daily tablets? I know, it sounds wild, but it's not science fiction. It's actually happening in research labs right now. And today, I'm speaking with Dr. Ming Lee, a consultant in sexual health and HIV, and also a lead investigator of something called RIO Study. This study is testing a new kind of treatment using broadly neutralizing antibodies, or better known as bNABs, that might one day allow people to take a break from their tablets and still keep the virus under control. Now, full disclosure, this episode may have some medical jargon. Things like broadly neutralizing antibodies, or remission, or viral rebound. But don't worry, I will break it down with photos, graphics, and examples wherever I can. And if anything sounds complicated, please make sure you drop it in the comments and I'll respond to it. I'm sorry in advance, but I've got you back. What I want you to know is this. People like Dr. Ming Lee give me hope. And they should give you hope too. Because I know that there is a lot of talk online that pharma doesn't want a cure, that will always be stuck on treatment. And yes, there are things to question. But behind the scenes, there are good people like Dr. Ming who are working quietly, passionately to get us one step ahead of this virus. So, if you are living with HIV or love someone who is, this episode is for you. And now, ladies and gentlemen, here's my conversation with Dr. Ming Lee. Thank you, Dr. Ming, for coming to Dose of Health podcast and talking to me today. Let me start by setting the scene, Dr. Ming. You know, we hear words like remission, we hear words like cure, functional cure, sterilizing cure when it comes to HIV. What do they actually mean in the real world?
Yeah, so thanks for having me on your podcast to talk about HIV cure. I mean, why do we still need a cure when we have highly effective drugs to treat HIV? And these drugs are known as ART or antiretroviral therapy, which, as you and many of your listeners know, it allows people living with HIV to live comparable life expectancies with minimal side effects, zero risk of transmission in the era of undetectable is untransmissible, and so on. But in light of the recent events in the world, I think we've seen that funding and access to these drugs are precarious and can be disrupted by global events. For example, the closure of the PEPFAR funding programs, leading to millions of people losing access to their antiretroviral therapy drugs, particularly in low and middle income settings. There are also lots of concerns around long-term side effects, treatment fatigue of having to take drugs daily, as well as the risk of drug resistance. So, because of all of these reasons, a cure remains an urgent priority for the community of people living with HIV.
Yes.
But what could a cure look like? I think we could talk about an ideal product profile of what a cure drug could look like. And
Yeah.
it should be something that's safe, something that's effective after a single dose in preventing virus from returning, even if people living with HIV stop taking their ART. And it should work for everybody living with the virus. And most importantly, it has to be affordable and scalable so that we can reach the populations who are most affected by HIV.
Yeah.
Bonus points if it can protect against future reinfections of the virus. And this may be achieved through what you've mentioned or alluded to as an eradicated cure. And what that means is if we can totally remove all traces of the virus in the body, which these viruses might be the source of virus rebound once someone stopped taking their tablets. We now have proof of concept that this is possible with up to 9 people worldwide with confirmed or potentially cured or in remission after they acquired HIV and then they underwent a stem cell transplant to treat another condition that they had, usually a cancer. And I can talk more about this later.
Yeah.
But it's a risky procedure and not one that we can offer everybody because of their side effects. So we can talk about other forms of cures that may bring us closer to this goal. You've mentioned remission. Could we have a drug like in cancer treatment that allows um, prevents the virus from returning during long-term sort of drug-free periods? So to give people a break from having to take tablets every day. But the expectation is that the virus will eventually return, and when this happens, they would have to restart treatment. There may be a functional cure, which means that the virus may still be detectable in the blood or in body tissues if we look hard enough after giving this treatment. But the treatment might have locked away the virus, and the virus is unable to replicate to cause any further damage or new infections. So these are all the possible scenarios which we could sort of look at developing a cure.
Amazing. So when I did the research on the type of cures, I came across remission, and I suppose remission is something that people talk a lot in cancer. It's cancer is not gone, but it's not spreading. And then you mentioned the Berlin patient, for instance. That is what we consider as a sterilizing cure. So it's a complete eradication of the virus. But the more research that I see happening is something what you call as the functional cure, which is our immune system has effectively learned to deal with the virus and it's not progressing towards the more notorious form of advanced HIV infection is what we call AIDS. Would that be a good summarization?
Yeah, I think the line between a sterilizing cure and a functional cure is still sort of being defined because apart from these cases of stem cell transplants, we don't really have any other agents as of yet, although that might change in the near future, as to what consists a cure and how do we sort of get to that stage. So these are all sort of hypothetical mechanisms of how we can reach a cure. And the truth is, in reality, we probably will end up with an agent that may sort of do a bit of one or the other, or start off as being a functional cure and then perhaps over time or in combination with other treatments, we can sort of aim to achieve a fully eradicative type cure.
Makes sense. Dr. Ming, my whole reason of doing this episode was because I run a YouTube channel where I teach about HIV. And when I go through the comments that people write in the video and do an analysis of what topic is of most concern to people, like, and I'm talking globally, it's almost, I mean, there's not even any comparison that everybody wants to know when is the cure coming. And I think from what I understand is what people are talking about when they think about cure is that they don't want to take tablets and they don't want disease progression. Basically, that's what it is. Because I think everybody understands that our body lives with plenty of pathogens, right? We've got a bacteria like Staphylococcus growing in our nose, on our skin, and trillions of gut bacteria. But our body manages it. Our immune system manages it. But with HIV, it just seems to be very drug dependent. If you don't take drugs in 10 to 15 years, in majority of the cases, the outcomes are not very good. So one of the things that people don't really understand, Dr. Ming, is why is HIV so hard to cure?
I think you're absolutely right in that sort of the key here is that the standard antiretroviral drugs that we use when people take it, although it's really good at suppressing the virus until it's no longer detectable in the blood, they can block the virus from replicating in active immune cells, but once people stop taking the virus, we expect the virus will come back, in 2 to 4 weeks, and it's detectable in the blood again. And the reason for this is because these drugs are unable to target the virus in cells that are inactive or latent. And this pool of inactive cells is what we call the HIV latent reservoir. So once you stop ART, some of these reservoir cells reactivate, reawaken, and churns out the virus that leads to the virus becoming detectable in blood again.
I see. So this latent reservoir comes into conversation plenty of times, and there has been plenty of ways that we have tried to tackle the latent reservoirs, right? And we've just been very unsuccessful. Is there a reason for that? Like we haven't been able to crack the code and it's been 40 years?
Yeah, I mean, there are a number of factors. Firstly, the virus itself, it's very, very well adapted and has many strategies, many tools in its arsenal to help evade the immune system. I think one of the key things is the fact that the virus has such a high mutation rate.
Yeah.
So it's a bit like in a spy movie where you see those scenes of spies changing their clothes, changing their outer appearances, hair colors, in a room of a party full of people, allowing them to go undetected. And it's the same with the virus. So the virus keeps changing and the immune system tries to keep up, but it's always a step behind. The virus is also able to induce the cells that it infects to go into this latent stage, which means it then sort of hides in these inactive reservoir cells and again sort of avoids the immune system. And finally, sort of the HIV specifically targets CD4 cells or the T helper cells, and these are the main cells that really signals and coordinates the rest of the immune system to fight off viral infections. And by targeting them, the body's unable to clear the virus.
It's fascinating, isn't it? The very subgroup of cells in our immune system that is meant to fight the infection, HIV is clever enough to attack that particular subset of cells and literally change the nature of it. And it's something that human beings, as you know, no matter how smart we are, we just haven't been able to get on top of it. And it's been 40 years.
Absolutely. A really, really sort of fascinating and clever virus in a way.
Absolutely. Absolutely. Let's talk about one of the cure strategies, Dr. Meng, something that you got involved in, and you were one of the lead clinicians. And that study was called the RIO study or the RIO trial. What was the big question that you were trying to answer through the RIO study?
So we were trying to investigate a new type of treatment called broadly neutralizing antibodies to see if they could be used to induce remission or to prevent the virus from rebounding once people stop taking their tablets in people who were living with HIV. I'll just explain a bit more about these antibodies. So antibodies
Yeah.
are small proteins produced by the immune cells to fight off infections, whether bacterial or viruses. They are really small, sticky proteins that can stick to a virus, coat it, and block their entries into cells. And
Right.
because of this, apart from blocking the virus from entering cells, they can also flag the virus or even cells containing the virus to passing immune cells, calling for help to remove or destroy these cells containing the virus. But because the virus mutates so quickly, naturally occurring antibodies to HIV are usually not effective in controlling the virus and are usually only specific to sort of that one strain of virus found in that one person.
Mm,
Very rarely, there are some people who've lived with the virus for a long time who've then produced antibodies that can recognize and bind to a broad range of viruses. So we call these antibodies that they produce broadly neutralizing antibodies or bNAbs.
I
So we,
see.
we can now identify these bNAbs from people living with HIV for a long time, purify these antibodies, and then use them as a drug to treat other people.
Wow. So would I be correct in saying that these broadly neutralized antibodies were found in patients who we called elite controllers? As in, like, this is a group of patients that have HIV and don't take antiretroviral therapy, but somehow their immune system still controls the virus and the disease doesn't progress. Is that where the bNAbs come from?
So interestingly, it wasn't from elite controllers. It was from people who've lived with chronic HIV, so long term, they've had the virus for a long time. And over this time, by the immune system interacting with and trying to catch up with this virus who's been mutating sort of throughout the years, the antibodies have evolved over time to become broader and sort of able to recognize more and more virus. Because in that one person, they've lived with the virus for years, perhaps even decades, and they now have, perhaps even hundreds or thousands of different subtypes of viruses with that one person. However, the virus is still always a step ahead of these antibodies. So these broadly neutralizing antibodies aren't effective for that person in controlling the virus. But once we take these antibodies out, purify them, and test them in the lab, we find that they can recognize and bind to a large panel of viruses. And that's why we think they'll be effective when given to other people with perhaps less diverse strains of viruses present. So, for
See.
example, people with early HIV infection.
Right, right. The primary HIV infection. I see.
That's right.
I
So
see.
people with primary HIV infection, which means they've acquired the virus recently, usually we take that to mean within 6 months. Let's say if they've had a negative test 6 months ago, they will have a really short period of time before they started on antiretroviral treatment, and that means the virus did not have time to mutate and would be very similar to each other. And so we think they'll be easier to treat.
Right. So that was the main reason why primary HIV infection patients were enrolled. Is that correct? Like most of all of the patients in that study were these early diagnosis patients.
That's right. So in the real trial that I worked on, we specifically invited people who were diagnosed in either primary infection or early HIV infection. They started treatment early, and then we enrolled them in the study, and they received antibodies and stopped treatment as part of the trial.
Brilliant. What made you take part in that study personally, Dr. Meng?
So, I mean, I think it was a great opportunity that I couldn't pass up, the opportunity to work on a really exciting new type of immunotherapeutic or drug that affects the immune system that might be able to boost the immune system to better recognize HIV. In clinic, whenever I see people coming in my clinic, apart from asking them about how they are taking their medications, if it's them causing them any side effects, one of the questions that would always come up is what's the latest news on the development of a HIV cure?
Yeah.
Perhaps at an early stage of my career, it was quite difficult for me to answer that because a lot of my training was focused on how do we manage the side effects, how do we deal with the acute complications of living with HIV. But that got me really interested into what was the research behind sort of developing new cures. And I was really fortunate to be able to work with some of the doctors who were involved in cure research studies, Professor Julie Fox at Guy's and St. Thomas's Hospital, who also introduced me to Professor Sarah Fiedler at Imperial College London, and Professor John Frater at University of Oxford, who were setting up this study, the RIO study, investigating these antibodies in collaboration with the Rockefeller University in the States.
Wow, fascinating. What was the treatment process like for the participants in RIO study? Like once you found these people, what did you do with them?
So they were all screened to see if the virus that they had would have any predicted resistance to these antibodies. So that meant that, did the antibodies recognize the virus? If it wasn't a match, then it probably wasn't the right time for them to enroll in a study like this, because the antibodies were likely not to work for these participants.
Yeah.
So for those people who were found to be have viruses that will possibly sensitive to these antibodies, they were then invited to undertake the antibodies, which was given through a drip as two antibodies given in bags of saline in the arm. Participants in this study were randomized 1-to-1, so half of them received the active drug, the antibodies, and half of them received an inactive drug, just a bag of saline or salty water. And 2 days later, they were asked to stop their standard antiretroviral therapies, and they would be very closely monitored, come in weekly for viral load testings to check their CD4 counts to make sure there wasn't any adverse side effects of these medications or stopping treatment. And we would see them every week until the virus rebound. At that point, they would then be asked to restart their medications once the viral load went up, for example, either above 1,000 copies for at least 6 weeks or above 100,000 copies, which was sort of the maximum reading we would allow it to go up to, or any other safety concerns, or if the participants themselves wanted to restart ARP at any time, they could choose to do so. And then they would go back on their treatment until the end of the study. Those who received a placebo could then go on to receive an open label or the active drugs that they knew were the actual bNAbs and go on to a second stage of the study. But I think for brevity, I wouldn't go too much into that detail.
Yes, of course. So let's talk about the stage one, the arm A. So you had these patients who were recently diagnosed, they're established onto antiretroviral therapy. You bring them in, you give them these broadly neutralized antibodies, and then after 3 days, is it, or 2 days, you tell them to stop their antiretrovirals. What was the reaction of patients? Were they quite open to it? Were they scared about it? Like, what was going on into patients' mind? Did they say anything to you?
Yeah, so I mean, we got to know the participants really well throughout this study, considering we saw them every week. And we also formally evaluated their responses in qualitative sub-studies. We had 2 led by Professor Day from the Goldsmith University, as well as Dr. Gohill from Imperial College. So what we wanted to do was not just look at the numbers and see, if their viral loads were suppressed, but really understand the impact of asking people to stop treatment in such long treatment interruption studies. And a lot of participants, because the message has always been to stay on their treatments, never come off treatment. It would be very bad if they do so. It is a bit counterintuitive to come off treatment.
Yes.
Once they're in a study like this, many of the participants have told us they felt reassured by being in such a closely monitored study. They had a lot of trust in their local clinical sites, their local clinical teams, and if there was any problems, they could contact the research teams soon to address any issues that they might have. That many of them were quite happy to continue. We've had participants who've remained off treatment for 2 to 3 years in a study, and without any concerns if their viral load remains undetectable and so on.
Wow.
We also have had a number of participants with their consent agreed to being filmed to talk about their individual experiences being in treatment interruption study, and this will also be available on the RIO website. So I do recommend any of your listeners to sort of come and visit riotrial.org to find out more.
Definitely. I mean, I'm going to look at it myself too. So let's talk about the results of the study. Like you presented, or your team presented the results in the CROI conference, one of the biggest conference for HIV globally, and it caught a lot of attention and a lot of people spoke about it. So simply speaking, what did you find in the results that you presented? Like after stopping antiretroviral, how long did the virus stay suppressed in these patients?
Our primary outcome was to see after 20 weeks, and we chose 20 weeks because that's when we were able to offer participants a second dose of these antibodies for those who chose to do so. But by 20 weeks after stopping treatment and after a single dose of these bNAbs, 3/4 or 75% of people who receive these antibodies remain off therapy, compared to only 9% or 3 people out of 34 in the placebo arm. And that
Wow.
was quite remarkable after a single dose. These antibodies are really long-lasting. And we were able to report, in CROI, we reported up to a year and a half that we still saw more people remaining off treatment compared to in placebo. So the numbers were 8 in the bNAb arm versus 2 in the placebo arm. And bearing in mind, these are antibodies that could be detected up until a year after the last dose. So these 8 participants might still have some antibodies left that's controlling the virus or not, but that's still a really remarkable result. And we'll be publishing the results soon in, well, we're currently submitting it for peer review, where we'll be able to report even longer sort of results up until 2 years.
Of course. So let me get this right in a very simple language. So what your study found was that after giving the broadly neutralizing antibodies, these bNAbs, and when you told these patients to stop treatment, 75% patients, so 3 out of 4 patients who stopped the treatment remained undetectable by week 20.
So they remain off ART. The criteria was to restart ART was viral loads above 1,000 copies. So if they had stayed off ART, it would be not all, most of them would have been undetectable, but some of them may not have hit that above 1,000 copies mark.
Fine. And just to give context, Dr. Ming, if we're just talking about general population and somebody who's established on antiretroviral and suddenly stops treatment, how long do you see after somebody becoming detectable and virus being shown in the blood test?
So that was actually the main reason why we had a placebo arm, because for people who were treated early in infection, there's been some studies that suggest that there may be a higher chance of people who can control the virus on their own without having to take medications. And there was a large study done by sort of colleagues in Denmark as well as Imperial College, and they've suggested that overall, across sort of all studies of people living with HIV, the overall proportion of people who could do this post-treatment control is about 4% or 4 in 100 people. But when
Wow.
you look at people who with early or primary HIV infection, that number rises up to 6%. So it's still a really small number. So
Wow.
6% of people by 4 weeks, the average time of the virus becoming detectable again was 4 weeks. And considering for the people who received the antibodies in RIO, this was 20 weeks on to 5 months after.
And there was a tiny proportion of people where they remained off antiretrovirals for over a year.
For
Uh,
over a year. In fact, up
over
to
a year.
18 months or yes, 72 weeks that we reported in the conference.
Well, that's definitely very promising, isn't it? Let's talk about the emotional side of this. What was the patient's response, if you remember any, after patients stopped ART and then they were just getting their viral loads undetectable 6 months, 7 months, 8 months time? Were they like elated? What was the reaction of people?
I think it's really interesting, and we're trying to explore that more in these qualitative studies where we ask people to describe their feelings and how they've ex how they've experienced this long-term sort of period of antiretroviral therapies. I think again, sort of we'll wait to see what these sort of formal results when they are being reported, hopefully later this year. But many of the participants, understandably, are sort of quite delighted by the progress. Yeah.
Excellent. I also read something, Dr. Ming, and correct me if I'm wrong, that these bNAbs also have this thing called the vaccine type immune boosting, where not only they are blocking the new virus or, potentially preventing the new virus, but they're also teaching the immune system to recognize future viruses so that it can even act like as a vaccine. Is that correct as well for
So
bNAbs?
So you're right in that that's absolutely one of the things we want to study. We can't yet say for certain that there is a vaccinal effect. There is a lot of debate in the scientific community about whether it exists, or whether these antibodies whether they just act like a drug in the sense that when they're present and detectable in the blood, they control the virus. When they drop below a certain level, the virus rebounds. So that's one of the things we are definitely studying and trying to tease out, for example, in these groups of people who've remained on heart for such a long period of time, is this because of the antibodies or is this because the immune cells are, are being taught to better respond and recognize the virus?
Of course. Was there a moment personally for you, Dr. Ming, where you thought, oh my God, we might be onto something really big here?
Yeah, so it's really interesting because as the study went on, we'll go, oh, look, it's 6 months, and there's some people who've still not had to restart medications, and oh, look, it's now a year, now it's a year and a half, and it's 2 years. And we've just gotten every person who's been in this study have provided such interesting results. And we found that these antibodies are safe. There's been no adverse events associated with the antibodies itself. And then we start seeing that perhaps there is a group of people, and of course, we were only recently unblinded. So up until the trial results were reported a couple of months ago, we weren't able to tell which groups they were in. Could they be the groups receiving the antibodies, or could they be the groups who've received the placebo? All we knew was that there was something really interesting going on.
Fair, fair. Now, on to a bit of a big question, Dr. Ming, that I'm sure people would want to know. Is this a step towards HIV cure?
So I'll firstly like to emphasize that I think on its own, we aren't saying that these antibodies are a cure just yet, and in terms of treatment, compared to standard antiretroviral drugs, they are, we would still recommend people take their standard antiretroviral drugs, which are more than 98% effective if taken daily, without the risk of drug resistance. But as we see it in a small group of people who seem to be controlling the virus longer than we expect, the next steps would be to try to understand what's controlling the virus. Is it the antibodies? Is it the immune system? And we have really clever colleagues in the labs in Oxford, in the United States, in Europe, who are sort of looking at the blood cells, looking at the immune responses against the virus, and hopefully we'll be able to tease out these results. And using these findings, we can then sort of try to understand how are the antibodies doing this,
Yeah.
try to work towards trying to strengthen these responses, perhaps giving the antibodies together with something else, other drugs. There's been some reports of, there's lots of other different types of cure-related research using different drugs to try to wake these viruses from these latent reservoir cells. So perhaps it could be in partnership with those or in partnership with a vaccine, which also stimulates the immune system. So perhaps we need one or all of these strategies together to be able to lead to a cure.
Fair play. So this is like one of the strategy step in the positive direction. Excellent. But could this approach be adapted in patients who are currently living with HIV for a very long period of time? Do they have hope?
So I think that's a really, really key question. And I think that's the next step for future studies, to include people living with chronic HIV or who were diagnosed at a later stage of the HIV infection before they started treatment. And certainly what we would like to see is a cure that would work for them as well.
Amazing. And mainly for patients who are living with HIV, if you were to directly speak to them, like what would be one piece of advice or a key takeaway you would want them to take away from this brilliant research that you've done?
So, I mean, the one thing I've learned from this study is we could not do it without the people living with HIV in clinic, their dedication and motivation has just sort of been overwhelmingly positive in this study. And what I would suggest to sort of any listeners who live with HIV, who are really interested in research, speak to your clinical teams, ask them sort of what are the available research opportunities, trial opportunities in the region. If not, they refer them to other clinical trials. For example, RIO, we are a growing collaboration. We started off being sort of 8 centers in the UK, that's now grown to 12 centers, both in the UK and Denmark. And we now have a third arm of the study, which is now including many European partners as well. So it's a collaboration that's growing, and we certainly would like to keep it inclusive as possible and try to invite anybody who might be interested to find out more through our RIO website or speak to their local clinicians.
Brilliant. You mentioned that it was just an infusion. Let's just say that going forwards, we are able to find a cocktail of bNAbs that is very effective in keeping the virus suppressed without needing to take tablets all the time. How easy was it to administer? Is it something that's kept in the fridge? Is there like with rilpivirine, we're worried about fridge, we're worried about the cost and all of that stuff. But putting the cost with regards to actual administration, was that pretty straightforward for bNAbs?
Well, I think you're absolutely right in that it has to be, especially when we're thinking about trying to roll this out to settings where they may not be, for example, having a cold chain might be a difficulty or a technical challenge, being able to store this uh, in more robust settings. So I'm sure the drug companies are looking into it. I have definitely seen sort of some studies where they've looked into giving this in different forms, not just as a drip, but also sort of subcutaneously.
Right.
And that might be something that eventually could be self-administered, but I think it's something that's still ongoing, and the drug companies are still looking into this.
Fair, fair. I'm going to ask you a difficult question, and you can choose to say no. You have worked in HIV for a long time. I've spoken to your colleagues; they speak incredibly highly of you. If you were to give your personal opinion, knowing everything you know about HIV diagnosis, treatment, and now like cure strategy, do you think that we will see a cure in our lifetime?
I think that is the million-pound question, or more than that. But honestly, I don't think I can give a straightforward answer.
Yeah, yeah.
What I can say, it's a really tremendously exciting time in the field, and the advances have been accelerating, particularly, I would say, after the COVID pandemic. We've learned a lot from sort of the research and development into immunotherapeutics, immune drugs to treat other infections. We've also learned a lot from the cases of people who've been cured of HIV through stem cell transplants. And it's incredibly sort of motivating to see that the original person who'd been cured, the Berlin patient, Timothy Ray Brown, who sadly passed away a few years ago, but he wasn't the only case. And I think his wish was that he wasn't the only case, and he was proven right. And now we have up to 9 other people who have been cured or potentially cured. And it just sets a route map to, firstly, we know a cure is achievable. We know that the immune system can be stimulated to clear HIV from the body. And the next steps are to find out a safe, effective, and scalable way to do this.
Amazing. Yeah. And God willing, I'm sure people like yourself, and hopefully with the help of this new technology like artificial intelligence and its ability to synthesize data so quickly, maybe, well, not maybe, but I personally feel very hopeful that this field is going to be accelerated to the next level. Last part of this podcast, Dr. Ming, I call it Dose of Health. So I asked this question to all of my guests, and I'm going to ask you as well. So if I give you a magic wand called Dose of Health, and you can wave it and change one thing in your field immediately, what would that be?
But this is a good question. It's a hard question because there are many things I would like wave the wand and sort of change and improve. You know, for example, the stigma that people are facing, which seems in this day and age, in the 21st century, in the era of U equals U, that it seems incredibly sort of upsetting that people are still living with such stigma that sort of stops them from taking tablets, from living sort of with a good quality of life. That's probably sort of the number one priority, dealing with the stigma of living with the virus. And the other issue is sort of equity of access, that, you know, even if we can develop treatments, we already have effective treatments, but not everyone can access them. And if we can sort of achieve equity of access to this treatment, that's something that I would certainly sort of push for and advocate for.
Two brilliant answers, you know. I think what the population is like 40 million currently living with HIV, and I think it's something crazy like 9 million who still don't have access to ART. And as you mentioned initially, the whole PEPFAR funding, the future, especially in the resource limited setting, the future is a bit uncertain at the moment, and hopefully things will get sorted and additional funding will come. Dr. Ming, thank you so much for finding time and chatting to me. You know, I didn't say it initially, but one of the theme of my comments that I get in the video are the one is like, when is the cure coming? But the second bit is like, patients get so fed up because we do not have enough information about cure and cure strategies out in the open for patients globally to understand. So automatically, I think a lot of people had this very hardcore view that maybe it's not in pharma companies' interest to find the cure. Nobody's working on it. It's all a myth. You know, doctors keep telling us that cure is coming, but nobody cares about us, was like the theme. And this was my effort to try and bring you to kind of give like a face to people who are working within this field, to say that, look, it is real. You know, there are people who have dedicated almost their life, God knows how many years you've spent, to look into this strategy, which is just one of the strategies. And then there are so many others, like you mentioned. So it is happening. There are people who are working, and you are one of them. So keep doing what you're doing. And thank you so much for finding time to talk to me today. If people want to find you, Dr. Ming, where can people find you? Are you available on social media?
Yeah, so I mean, firstly, I just want to say huge thank you to you for sort of inviting me on this podcast and to share and talk about this really important topic, as you say. So it's lots of interest in this topic, and to sort of bring this information out there. So really grateful for the opportunity. So you can find out more about the study, the RIO study, on the study website, riotrial.org. And also I'm online on social media, including on LinkedIn, under Dr. Ming J. Lee, or on Blue Sky as well.
Amazing. I'll find out your socials on Blue Sky and actually put it in the show notes. Thank you so much for talking to me. All the best, Dr. Ling.
You're very welcome. Take care. Bye.